Well, thank you very much. I too would like to thank the organizers for the invitation to come here. It's been a great pleasure. It's also been very informative, something I don't delve into every day. I want to talk about periodontitis or gum disease and the relationship or the potential relationship of omega-3 fatty acids and their products as therapeutics. I don't imagine everybody in the room knows a lot about periodontal disease. This is one of the most frequent diseases of mankind. We heard yesterday about cardiovascular disease affecting 1 in 3 people. Periodontal disease affects 1 in 2 people in a moderate or severe form. There's 2 major types of periodontal disease: gingivitis, or redness of the gums, it's what happens when you don't brush your teeth. Okay. It's reversible with good oral hygiene. However, if it's left untreated, gingivitis may advance to periodontitis, which is the more advanced form of the disease. Tissues and bone that support the teeth are broken down and destroyed, and results in loosening of teeth that may need to be removed.
There was another disease pattern that occurred.
And there's an increased risk for other systemic problems, which I'll talk about in a minute. There are many treatment options available that include both surgical and non-surgical therapies, most of which will arrest the disease, but are really very ineffective at regenerating any lost tissues. Okay. All right, so periodontal disease, as you see from here, this slide, everybody starts out with a healthy mouth. Gingivitis occurs when you don't brush your teeth often enough and you start to get redness of the gums, as you can see here, which is associated with the accumulation of bacteria. Periodontitis is, as you can see from the diagram, when you start to lose the bone around the teeth and you get pocketing between the gum and the tooth. If anybody's been to the dentist recently, they take that nice sharp piece of metal and slide it down between your tooth and gums. Very favorite thing for periodontists to do. They're looking for these pockets, which are diagnostic of the disease. And as you can see here, in advanced periodontitis, there's a lot of accumulation of debris on the teeth. This is bacteria as well as calcified deposits, but you can also see all the loss of soft tissue and bone that's associated with the advanced disease. Great pictures for after lunch, don't you think? But this is an inflammatory disease. And inflammation, as we know, can be damaging when uncontrolled. And the issue with periodontitis is that chronic inflammation occurs when there's a sustained infection. So while the etiology, it's a very interesting disease, it's actually one of the more complex diseases because it involves all of the tissues of the body, both hard and soft. It's an infection, but the infection itself does not damage the tissue. It's the host response, the inflammation, that is responsible essentially for all the tissue destruction that we observe in periodontitis. So chronic inflammation is in response to the sustained infection as periodontitis. It involves more inflammatory mediators than the immediate innate response. In other words, as the lesion matures, we get a very robust inflammatory immune response. And this can affect all organs of the tissue and tissues of the body. And chronic diseases of aging connected through the common chronic inflammatory mechanisms include periodontitis. So periodontitis, type 2 diabetes, cardiovascular disease, arthritis are all related through the same, more or less, inflammatory mechanism. And it's been shown now that one has an impact on the other. To that point, periodontal disease has been associated with poor metabolic control in diabetics. This has been very well documented in prospective studies. Your risk for coronary heart disease is increased by periodontitis, as is non-hemorrhagic stroke and peripheral vascular disease. And the risk for low birth weight children and pregnant mothers with periodontitis is also increased. The risk for respiratory infections is more of a physical problem. This is concentrated in people in facilities, long-term care facilities where their oral hygiene is terrible, and they're also old and have trouble swallowing, and they aspirate bacteria and get pneumonia. So that's really a different pathogenesis. But the point is that periodontitis has a huge impact, or potential huge impact, as a cofactor in progression of all the diseases that we heard about yesterday. Okay, so this slide is to illustrate the idea that periodontal disease is an inflammatory disease, but it also relates to the interest in my work, which began in 1997 when I began a collaboration with Charlie Serhan at Brigham and Women's Hospital. Charlie and I have several grants ongoing today, and actually Gerard Bannenberg has part of this process when he was a postdoc in Charlie's lab. We have been studying the relationship of the metabolic products of omega-3 fatty acids, the resolvins, and their impact on inflammatory disease, particularly periodontal disease, but also type 2 diabetes and cardiovascular diseases. I will just show today some of our work with periodontal disease. So the lipid mediators of inflammation, which we probably know a whole lot about, but I just thought I would review this quickly. We know a lot about the pro-inflammatory arachidonic acid-derived mediators, the prostaglandins and leukotrienes, but Charlie's discovery is really pro-resolution, the active process of resolution of inflammation that is mediated by arachidonic acid-derived molecules such as the lipoxins and the aspartame lipoxins, as well as the omega-3 fatty acid-derived E-series resolvins from EPA and D-series resolvins from DHA. It's important to note that these are all receptor agonists, so this is a feed-forward system to shut off inflammation naturally, which is in sharp contrast to all of our pharmacopoeia today, which is all inhibitors or antagonists. So the specificity of these molecules is exquisite because they bind only to their receptor. However, things like ibuprofen are very, very nonspecific and have a lot of side effects. The role of aspirin is also very important because it modifies both resolvin and lipoxin molecules and makes them longer acting in circulation and increases their activity as a result of that. If you really want to know the mechanism of that, I'll be happy to talk to you after the talk. The important thing here, for instance, to note is we talked about the effect of omega-3s in cardiovascular disease in the GISSI study. What most people don't think about is in the GISSI study, everybody had just had a heart attack and everybody, including the control group, was taking low-dose aspirin. So the effect that was observed was a combination of omega-3s and their aspirin-triggered products. So the idea here is that resolution of inflammation is an active, temporally controlled feed-forward system regulating resolution of inflammation. And we published this figure in Scientific American some years ago, but what it's trying to illustrate is that our current pharmacopoeia, which acts on all of the different arms, if you will, of the inflammatory process, selects one at a time. So nonsteroidals block prostaglandins, Enbrel and Humira block TNF, anakinra blocks IL-1, etc. The resolvins act on all of these things at the same time, which is why there are no side effects that have been identified to date. And in fact, you get a coordinated return to homeostasis. Now, how does this relate to periodontal disease? Oh, one more point. Why don't host modulation drugs with anti-inflammatory agents work very well? We know that we can arrest periodontal disease as well as a variety of other inflammatory processes with COX inhibitors, TNF-alpha antagonists, steroids, obviously, and statins, interestingly, have very potent anti-inflammatory properties, but all have unacceptable side effect profiles, and we think it is related, in fact, to the lack of specificity for shutting down these pathways whereas in theory, the resolution of inflammation agonists will not have these side effects and will be more potent. And to make things even more complicated, most current anti-inflammatory agents, the inhibitors, actually interfere with the production of resolvins and lipoxins, and we call this resolution toxicity. Everybody remembers the drug Vioxx. It was taken off the market because people started having heart attacks with chronic use, and this is an example of shutting down the pro-resolution system and allowing for low-grade inflammation, which resulted in cardiovascular disease. Okay, so on to periodontitis. We did an experiment with resolvins in rabbits. Rabbits are our model for periodontal disease. They're also our model for cardiovascular disease. I'll only show you the periodontal data today. But basically, we induce disease by tying a ligature around the second premolars and then applying a human periodontal pathogen, which is called Porphyromonas gingivalis, every other day for 6 weeks. At the end of 6 weeks, we stop the Porphyromonas gingivalis application, sacrifice one group of animals to quantify how much disease we've created, and then begin either RVE1 or vehicle therapy as a monotherapy. In other words, we're taking, in this experiment, 10 micrograms or milligram per mil solution, taking 10 microliters and placing it on that ligature 3 times a week. For the next 6 weeks, and at week 12, we sacrifice the animals and quantify disease. This is the soft tissue picture in this experiment. We're looking at periodontal disease at 6 weeks. For those of you who don't examine rabbits every day, okay, this is the the tooth that was ligatured. You can see the inflammation. You can see the loss of tissue compared to the adjacent teeth. And with vehicle treatment, you can see that not much changes. We have a little less clinical inflammation, but we still have all the loss of tissue, particularly between the teeth. When treated with RVE1, the most striking thing immediately is that there's a remarkable absence of inflammation, but you also note that all of the lost tissue has filled in the interproximal spaces and the teeth are no longer as long. When we quantify this, I talked about the periodontal probe measuring the pocket depth between the teeth. What you can see is that at 6 weeks in the orange here, that we've created about a 4 millimeter pocket depth, which is clinically substantial since the teeth are only about 12 millimeters long. So they've lost a lot of attachment and bone. Interestingly, in the second 6 weeks with the vehicle treatment, the disease progresses to the extent that the teeth actually become very loose. And with RVE1 treatment, you can see that that tissue and its attachment to the tooth is returned to pre-treatment levels. When you look at the osseous tissues, now here we've defleshed the skulls and we've stained the jaws with methylene blue so we can take pictures. At 6 weeks, you can see that we've created significant disease. You see the bone loss between the teeth, which is quite obvious, as well as how long the teeth are. The vehicle treatment, not much has changed other than the fact that the bone loss actually is more severe. So the disease, again, has progressed. In RVE1 treatment, what you can see is that all that bone that was lost around the teeth seems to have regrown back to pre-treatment levels. Just parenthetically, for those of you who don't know much about periodontal disease, regrowing bone in periodontal disease therapy is the holy grail that we're still searching for. Nobody has ever been able to grow bone before. This is the hard tissue regrowth quantification. As you can see, we lose additional bone with the vehicle, and that all that interproximal bone grows back in the RVE1 treatment. Okay, so armed with that, we have now moved on, and we are actually in human clinical trials with a resolving agent. It's actually a lipoxin which is in phase 1. I don't know how it's going, of course, because it's blinded, but we will see how this works in humans. But the take-home message is that the active component of omega-3 fatty acids is actually quite potent in reversing periodontal disease in the absence of any other type of co-therapy. Now, the last thing I want to tell you about is a clinical trial that we did. It was really a field study where we wanted to ask the question, all right, so if this works so well in animal models, and we've done it in mice and pigs and various other animals, which is all published, will the omega-3 fatty acid, in the presence of aspirin, again, because we're trying to enhance the production of the resolvin that's longer acting, work as a therapy in conjunction with standard periodontal therapy. So this is a study where we use dietary supplements. I can't tell you the brand right now, I don't really remember. It's in the paper. And the standard therapy, initial therapy for periodontal disease is something called scaling and root planing. That's when you go to the office and they anesthetize your jaw, and then they take these instruments and scratch on your teeth, making horrible noise. And that removes or debrides the wound and allows for healing. Okay, so we are now using dietary supplements that are either active or inactive in a prospective trial, which is 6 months. So we had 80 subjects with severe periodontitis, 40 per group. One group got scaling and root planing plus 900 milligrams of EPA, DHA, and 81 milligrams of aspirin. The EPA, DHA ratio in this particular preparation was 50-50. It was a commercial product, which is the reason we have 900 milligrams. We were trying to be as close to the gram a day that was used in the GISSI study, because this was done in 2008, as you saw, and 81 milligrams of aspirin daily. And the regimen was kept up for 6 months. Group 2 had the same physical therapy, the scaling and root planing, but the placebo tablets, because there was one for aspirin as well, daily for 6 months. We made all the periodontal measurements, made a baseline 3 and 6 months. We also measured a series of inflammatory mediators in saliva. This is just the demographics of the group. As you can see, they were age age matched. The ratio of male to female was roughly the same, and the number of teeth was roughly the same. Now, this slide basically has all the data, summary data from the trial. I want to focus your attention to the bottom panel here, which is the differences between the groups. So we have the group taking omega-3 at 6 months and the control at 6 months. And what you see is there was a reduction in bleeding of the gums, which was in favor of the omega-3 group, which was not statistically significant. But the average pocket depth was statistically significantly improved. 0.6 millimeters doesn't sound like a lot, but we'll talk about that in a second. And the attachment level, or the reattachment of the gums up the tooth, was also measured, and that was also improved statistically significantly. The amount of inflammation that was measurable or the amount of bacteria on the teeth were not different between the groups. Now, just to digress for a second about millimeters, okay? There are actually 168 sites in the mouth where we measure the pocket depth, okay? And then we take an average of that. Most of those sites don't change, and so the average is always very small in these studies, and all of the antibiotic treatments, there's a whole series of studies for products that are marketed for the treatment of periodontal disease. And the change, the average change, is always roughly 0.6 to 0.8 millimeters. What's relevant, more relevant, is the frequency distribution of sites that need further treatment, okay? And that's what's represented in this slide. If we look at the frequency distribution of periodontal probing depths, okay, sort of confusing and hard to grasp if you're not a periodontist, I think, but bear with me. If you have pockets that are 4 millimeters or less than 4 millimeters, you don't need treatment, okay? If you have 4 to 6 millimeter pockets, you have moderate disease. Greater than 7 millimeter pockets, you have what's called severe disease. And this is the frequency distribution of that at baseline for the two groups, the control and the omega-3 plus aspirin. You can see at 3 months, the number of sites that go from needing treatment to not needing treatment after scaling and root planing goes up about 5% in the control group, goes up about 10% at 6 months. If you look at the omega-3 group at the same time, you can see that going from baseline to 6 months and 3 months as well. But the difference here is that 50% of these people still need 30, or sites still need further treatment, whereas here it's down to 20%, and this is highly statistically significant and gives an idea of how much treatment you're saving the patient by simply supplementing their diet with omega-3 fatty acids. The attachment level gain gives us the same type of data, except this is gain, so it goes the other way. So 74 to 71 versus all the way down to 25%. So the conclusion we came to from this study is that dietary supplementation with omega-3 fatty acids and aspirin as an adjunct to routine therapy has a significant impact on the outcome of the clinical treatment, and that this is a safe, sustainable measure aimed at the reduction of systemic inflammation that in fact may have a benefit in the prevention and treatment of periodontal diseases in susceptible individuals. So one last thing that I do want to mention as it relates to the relationship between periodontal disease and other systemic diseases is that in studies that have been published now in ATVB and other places, we've been able to show that treatment of periodontal disease has a very, very significant impact on cardiovascular outcomes in the rabbit model, to the extent that if we treat periodontal disease, we can actually prevent atheroma formation. And if we supplement that treatment with omega-3 fatty acid derivatives, the resolvins or the lipoxins from arachidonic acid, we have a remarkable impact as well. The other thing we've been able to do in a model of cardiovascular events in the rabbit is, in fact, in the control group, where we treated with topical application of 10 micrograms of resolvin to the gingiva in the absence of periodontal disease. The experiment was to induce cardiovascular events after creating vulnerable plaques. We saw two things. Number one was the administration of RVE1 to the gums actually reversed the cardiovascular lesions in the aorta. And secondly, in the control group, there were 21 cardiovascular events, and in the resolving group, there were 1. So I think this shows two things. Number one, periodontal disease is important in the progression of other systemic diseases. And number two, that controlling inflammation with the active metabolites of omega-3 fatty acids has a huge impact on the progression of both periodontitis and cardiovascular and other inflammatory diseases. So with that, I'll stop, and thank you very much for your attention.